Child abuse is a serious public health problem. It includes physical, emotional, and sexual abuse, as well as neglect. According to the Centers for Disease Control, in 2021, it is estimated that 1 in 7 children in the United States has experienced child abuse or neglect. Children who suffer from abuse or neglect are at risk for not just immediate physical injuries, but are at risk for chronic health conditions, delayed brain growth and development, educational difficulties, poor mental health, and behavioral issues, just to name a few. Did you know that there are doctors and nurse practitioners that specialize in caring for children that have been affected by abuse? These are medical providers that specialize in identifying and treating children that have suffered from abuse and neglect. These doctors and nurse practitioners often testify in court to help a jury understand medical conditions and injuries that may have occurred from abuse or neglect.
Forensic nursing is a fairly new and unique specialty that incorporates nursing, forensic science, and the justice system. Forensic nurses have a significant role outside of the hospital or medical setting. They advocate for healthcare policy changes and strive to help those affected by violent crime. They work closely with law enforcement and the legal system. Forensic nurses have a significant role in the criminal justice system, providing clinical expertise, education, and teaching about the medical legal evaluation of patients affected by violent crime. In the 1970s, there were a few ER nurses that started to notice the need for specialized care for patients they saw in the emergency room that presented after being sexually assaulted. The first sexual assault nurse examiners, or SANE nurses, came from 3 different states: Texas, Tennessee, and Minnesota. These small programs recognize SANEs as nurses or nurse practitioners who received specialized training to care for patients that had experienced sexual assault and were trained to collect evidence and testify in court. And then in 1992, a small group of mostly SANE nurses from the US and Canada came together to form the IAFN, or the International Association of Forensic Nurses. And the goal was to create a nursing organization that specialized in caring for and treating victims and perpetrators of violent crime. What began as a small group of 72 nurses has now grown to over 6,000 members as of December of 2022, and there are 30 chapters of the IAFN around the world. It was not until 1995 that the ANA, or American Nurses Association, recognized that forensic nursing is a formal nursing specialty. There are many different specialties within forensic nursing, including SANE nurses, sexual assault nurse examiners, FNEs, forensic nurse examiners, death investigators, nurse coroners, corrections nurses, legal nurse consultants, nurse attorneys, and there are also nurses that specialize in human trafficking, elder abuse, child abuse, and forensic psychiatric nurses. Forensic nursing is a quickly growing field to meet the public health needs. The goal of this podcast is to introduce you to some of the different roles within forensic nursing. This episode today will be one of several episodes highlighting different specialties within forensic nursing.
So I have Gail Horner here. She is a nurse practitioner, works in many roles, one of them being working for the International Association of Forensic Nurses and child abuse nurse. So can you just introduce yourself and your role and what your experience is?
I'm Gail Horner. I am currently a forensic nursing specialist with the International Association of Forensic Nurses, where I support the practice of forensic nursing across the country and really across the globe. Prior to joining IFN about a year ago, for the previous 28 years, I worked at Nationwide Children's Hospital in Columbus, Ohio, in a role as a pediatric nurse practitioner in a hospital-based child advocacy center, where I kind of worked in, you would say, 3 different clinical roles. Well, 4 different clinical roles there. One was we had the typical CAC assessment clinic, where we would see children for concerns of sexual abuse and physical abuse. And I performed the physical exams for those children. And then also we had a primary care clinic for children in foster care. And so I functioned as a primary care provider in that specialized clinic for children in foster care. And then also for physical abuse, for children where there was a concern of physical abuse that was severe enough to require hospitalization. I performed, they were called inpatient consults of kiddos where there was a concern of physical abuse, which involved obtaining a history from the caregiver and physically examining the child, consulting with radiology, neurosurgery, general surgery. So those were kind of my 3 roles in the Child Advocacy Center. And then I also coordinated a team of sexual assault nurse examiners in our emergency department and took call in the emergency department for the same program. And then also, I was really blessed to work at Nationwide Children's Hospital, a very resource-rich environment. And so I had the opportunity to perform like clinical research projects and to and have the statistical support to be able to do that, because I'm not a PhD. I have no idea about stats. And then also I had time to also just publish articles discussing various topics related to child maltreatment.
Wow, it's quite an extensive experience. How did you get into working in pediatrics?
In pediatrics, actually, I worked at Nationwide Children's for 41 years. So pediatrics, I just knew from nursing school that I wanted to be a pediatric nurse, that I wanted to work with children. And so for the first, I can never do the math, 13 years of my career, I worked as a staff nurse on a variety of inpatient units. And then I went back to school and became a nurse practitioner. And then honestly, when I graduated, the only position that was open was child maltreatment. So I thought, oh, what the heck? I want an NP job. I'll go for it. So I joined that team and I never regretted it. I truly found a population that I was very passionate about. I certainly think prevention is where we should be with child maltreatment, because it certainly is preventable. And I truly think that's where we should be focusing a lot of our efforts on. And certainly the prevention of re-abuse, which happens all too often.
So a lot of your role was educating families and...
yes, certainly there was education of families that was involved in my role, and also educating other healthcare providers regarding how to recognize abuse in their patients, how to screen for risk factors, and how to address those risk factors. Because when you look at the risk factors for child maltreatment, all those psychosocial risk factors, if we in pediatric healthcare, I think, did a better job of identifying those factors within the families that we work with and linking them with affordable evidence-based resources, and really monitoring to make sure that they do link and that they are following up with what was recommended, I think we could really make a difference in the lives of children.
Yeah, I do see a lot of, in the emergency room and, and in inpatient areas too, patients that through and And do you think forensic nurses have a different perspective, like working with like cases of child abuse and, as opposed to like I previously worked in a level 1 trauma center. So, just as regular nurses, we saw a lot of, child abuse just on, like in the burn unit and then the ICU. And but how do you think forensic nurses have a different perspective?
Don't you think? I think forensic nurses see the broader picture. They kind of see, they just see not just what has happened to this child, but they understand on some level why this has happened to this child. And I think that's what's so important, because, the more that I worked with the families that I would work with, I realized, thank heavens I was born to the parents that I was born to, because that really makes
Right.
such a huge difference in life. And
Right.
that
Right.
when it's all said and done, I don't know that everyone can be judged on the same scale, because
Hmm.
it, there are certain things in life that are much more difficult to get over. And so,
Right.
so I do think forensic nurses have more of an understanding of that.
Hmm. Hmm. Yeah. Yeah. I agree. Yeah. And yeah, I guess working in a big children's hospital, then you must have had a lot of support from, like social
Mm-hmm.
work and, all,
Mm-hmm.
yeah, like a whole
Yeah,
team
yeah, it
of,
was a multidisciplinary team. Certainly for the
hmm
physical
yeah,
abuse assessments in our child advocacy center, multidisciplinary
yeah,
team assessments, and in our foster care clinic, also we had access to social work, and also
hmm
relationships with child protective services for the children in foster
yeah,
care.
yeah. And so you were involved in kind of follow-up care as well, it
Uh-huh.
sounds like.
Yes. Like once a child entered care, our clinic functioned, and it continues to function as a primary care clinic for some of those children.
Yeah. And then just, of course, working with such a difficult population, like what does your organization do, like to help prevent or deal with like vicarious trauma?
At Nationwide Children's, we had oh shoot, what was that team? It's like a crisis team that when there would be a really difficult case, be it in the
Hmm.
emergency department, on an um, inpatient unit, be it in the child advocacy center, we had social workers that could come and talk to us individually or as a group, so that we could kind of decompress. I think most
Yeah.
importantly, we worked as a team, and so we used each other to kind of vent when something got to us. We had our coworkers who understood what was
Right.
happening and what we were somewhat traumatized by hearing or seeing. And so it was a
Hmm.
good, cohesive group of multidisciplinary team members who were a source of support to
Yeah.
each other.
That's great. I know my experience, like working in the emergency room, like we go into a big pediatric trauma code. It's this terrible situation. It's just, just a big flurry of activity and then it's done. And then you've got to move on to the next thing. And there's oftentimes not time to debrief or discuss. And really, because a lot of those
Yeah, I do think in healthcare,
patients still,
that's something
yeah.
that we don't do enough of, is taking care of the
Hmm.
carer.
Right. Just a couple more questions. So I'm almost done here. If interested or nurses are interested in this kind of work, would you recommend them getting their nurse practitioner, or how would
I
nurses
think
kind of
it
pursue this kind
depends
of
what
field?
exactly you want to do.
Hmm.
um, because you can be a pediatric forensic nurse without being a nurse practitioner. In many areas, you're
Right.
probably limited to working with victims of sexual abuse as a registered nurse, but there's some crossover now with physical abuse, with registered nurses
Hmm.
providing care of physically abused children. I have to say, I never
Hmm.
regretted my decision to become a nurse practitioner. It's certainly never regretted it. I'm so glad that I went back to school and completed my NP. So I would never say don't do that. But I think
Hmm.
in forensic nursing, you don't have to be advanced practice. You can practice
Yeah.
as a forensic nurse without advanced practice. In our SANE program, the majority of our SANE nurses were registered nurses as opposed to
Hmm.
advanced practice. Um,
Hmm.
yeah, I mean, I truly think you just choose what works best for yourself. Um,
Hmm.
I enjoyed having that variety in my position, like the primary care role. I very much enjoyed that as well. And that is something you'd have to be an NP to complete that role. But,
Right.
I never regretted becoming an NP, but I also enjoyed being a staff nurse, a bedside nurse. So
Yeah.
I can't say that. Yeah, I think you just have to decide what you want to do with it.
Is there anything that surprised you about working in this field, like in child abuse specifically, or?
Um, Surprised me. Well, I think certainly I will say this from when, okay, I'm an old lady. So I started working at Nationwide Children's in 1980. And to see the
Uh-huh.
evolution of, I can remember taking care of like physically abused children. I worked on an under two medical surgical floor for children under 2 years of age. And I can remember alleged perpetrators being able to visit. I mean, social work would come and talk to them, but honestly, there wasn't much of a child protective services presence, and these
Wow.
individuals were allowed to visit. Um, I Children were discharged to families when it was clear that they had been abused, and yet then over time certainly we became more aware of the fact that these children had to be protected and that individuals had to be held accountable. And currently an alleged perpetrator is not allowed to visit. Child protective services takes custody of the child. um, Child protective services ultimately makes the decision as far as discharge. Is it safe to return home, or do they need to look for alternative care? But certainly when a child is hospitalized with injuries severe enough to require hospitalization, typically children's services is they're very much looking to protect that child and looking for
Yeah.
alternative placements for that child. It's just much different than it was
Yeah.
40
We've come a
years
long
ago.
ways.
Yes.
Yeah.
And sexual
Wow.
abuse,
Yeah.
my goodness, in 1980 was not a thing at all. Not that was recognized really.
Wow. Right. Wow.
In fact, now
Yeah.
this was before my time in the program, but our founding medical director, Dr. Charles Johnson, who truly was one of the pioneers in child abuse pediatrics, he said there was a film, I forget the name of it, but it was about a little girl who had been sexually abused. And that was shown in like 1983, 1984. He said the next day after that television, it was like one of those TV movies. When it was
Oh,
shown,
yeah.
there was a line of families waiting to be assessed due to concerns of sexual abuse.
Oh,
Yeah.
wow.
So, I mean,
Wow.
really, until the 80s, sexual abuse was
Yeah.
not even addressed at all.
Wow. It's
Uh
hard to
huh.
believe, right? Yeah. Wow. And then just last question, is there anything else you'd like nurses to know about your role in the field or forensic nursing in general?
I think people get, even my daughter, who's a nurse, doesn't want me to talk
Hmm.
about never wanted to hear anything about any patients. It, she's just kind of traumatized by almost
Yeah.
hearing the stories. And I think what nurses need to realize that there's something empowering about being able to help a child in a family who is in a difficult situation. I mean, I'll be honest, when I took call in the emergency department, when my pager would go off at 3 o'clock in the morning, I wasn't turning cartwheels saying, oh, yippee, I get to come in.
Right.
But I would go in and I would care for that child and that caregiver. And I would like to think, and many times 3, 4 hours later, I would walk out of there thinking, I've done something. Like maybe I've made this awful night, maybe the worst night of that child's life, a little bit better for them and their
Yeah.
caregiver. And I think that
Yeah.
in its essence is what forensic nursing is about. Look, working
Yeah.
with people who are maybe in the worst spot that they've ever been in and making that experience a little bit better.
I think a lot of people, even nurses, were not aware that there are providers and nurses that specialize in child abuse. This is just one of the many subspecialties within forensic nursing, and it's been really interesting hearing about your role as a child abuse nurse practitioner. Gail, thank you so much for sharing about your experiences. The medical legal death investigation system conducts investigations that identify the cause of death due to natural or unnatural causes. Unnatural or unexplained deaths could be due to homicide, suicide, accidents, or maybe drug-related. There are about 2.4 million deaths in the United States annually, and about 20% are investigated by medical examiners and coroners, which is about 450,000 investigations a year in the United States. Investigating the cause of death is essential from a public health and research perspective. Knowing the cause of death helps with epidemiology and prevention programs like injury prevention and prevention of substance abuse, suicide, and violence. According to the International Association of Forensic Nurses, the IAFN, each state or county in the United States handles death investigations differently. In the United States, either a coroner or a medical examiner is responsible for investigating deaths. Coroners are elected officials, and depending on the jurisdiction, they may not have any medical background at all. Medical examiners are generally physicians with a background in forensic pathology. Many jurisdictions in the United States use nurses as coroners or death investigators. In the United States, there are 11 states that use coroners, 22 states that use a medical examiner, and 18 states that use a combination of both medical examiner and coroner. There are not enough physician medical examiners to fill all the needs in the United States, and forensic nurses are well positioned to work in the role of death investigator. Death investigation is another subspecialty of forensic nursing. These nurses go out to the scene of a death and help with the investigation and documentation after a death. For nurses interested in this field, it is recommended to obtain a strong background in emergency and intensive care, to develop strong assessment and interpersonal skills required for work that death investigators do. Nurses that already work in forensics have received training in evidence collection, detailed injury documentation, and forensic photography, which are all valuable skills that are used in the death investigator. My next interview is with Kaylen Knight. He is a forensic nursing program supervisor for a hospital-based forensic nursing program that sees patients who have been affected by sexual assault and domestic violence. Could you just introduce yourself, your role, your experience, and how did you get into forensic nursing?
Absolutely. So, my name's Kaylen Knight. I'm from Omaha, Nebraska. My primary role is I work as a forensics nursing program coordinator for a hospital-based forensics nursing program. In that role, I primarily focus on sexual assault and domestic violence. However, outside of that, I also work as a medical examiner investigator for a county-based medical examiner system in Iowa. My background was primarily emergency department nursing and trauma nursing. And then after doing that for about 3 years, I transitioned to a nurse educator role for the emergency department. And that's where I really started to learn a lot more about forensics nursing. So I sought out the sexual assault nurse examiner training, and then I came across the death investigator training, and I really wanted to pursue that as well. So that's kind of how I ended up here. It was kind of a odd pathway for me, but I just kind of learned that I really enjoyed forensics, and that's how I ended up where I'm at.
Nice. So your program does sexual assault and IPV as well, exams, it sounds like. Yeah. Okay. And then,
Yes.
I just have a few questions about the SANE and FNE role. So since nursing and SANE especially have traditionally been a female nursing role, as a male FNE and SANE, have you run into any challenges with patients, providers, anybody in the community? Has that been a challenge for you?
Honestly, when I first became a nurse, I wanted to seek out the SANE training, and I was kind of talked out of it by a few other healthcare providers who just didn't feel that men as a sexual assault nurse examiner was really a good idea. So I just kind of let it go. And then about 3 years later, some new leadership came along who said, I really think our program could benefit from having a male sexual assault nurse examiner. So I sought out the training, and since getting the training, I have never encountered a patient who was not okay with having me. I've never had any issues with any healthcare providers. I would say that the most important thing as a male in this field is I spend a little bit more time building rapport with my patients, and then making sure that they know I'm here for them. And if there's anything they're not comfortable with, they just have to say so when we stop. And then also our program, regardless of the gender of our forensics nurse examiner, we always have a chaperone present for our exams as well. So that sometimes also provides an extra layer of comfort for our victims who are seeking care.
Oh, that's interesting. Yeah, that is a little bit different than other programs. Yeah. Yeah, I think it's really valuable to have, some diversity and, amongst providers and especially, in that role. I know that in my practice, we do see a fair amount of male patients, and it's not just females that are our patients. So I think that's really important. I wanted to focus a little bit more on your other role, because I don't know much about, you also work as a medical examiner investigator. So what exactly does that role entail?
Absolutely. So you'll find that when you research the role of a death investigator, it varies dramatically from state to state, which I never knew. So like I live in Nebraska, who utilizes the coroner system. So they don't have death investigators. It's primarily done by law enforcement on the scene. So when I was seeking out a role like this, I actually had to cross the river from Nebraska over to Iowa, where they utilize the medical examiner system. And the medical examiner system typically, again, it varies from state to state, but in my region, we have a physician who is our medical examiner, and then underneath our physician is the chief medical examiner investigator, and then under our chief investigator is all of the medical examiner investigators, and that's where I am. So what we do is we're only an on-call system. So I have about 9 individuals on my team who we just take a call throughout the month. And we're on call for all deaths that occur outside of the hospital or any deaths that occur in the hospital within 24 hours of admission. And there's 2 types of calls that we can do. There's something called a jurisdiction decline call, where we call the law enforcement officer or the nurse on scene, and we get a little bit of background information to determine if this is a medical examiner case that could potentially require an autopsy or not. If we think it's a natural death that we don't need to intervene on in any way, we consider a jurisdiction decline and we don't go to the scene. If it is a case that occurs outside of the hospital that is not on hospice, we have to go no matter what. And those, we go to all calls. So natural deaths, where it could be an elderly individual who is just found deceased in their bed. We have accidental deaths, where it could be car accidents, falls. We do suicides, we do homicides, and then we also do, when circumstances just are questionable, where law enforcement isn't really sure where to go about it, we come on scene and we conduct our own investigation.
Oh, interesting. So it sounds like it's similar to the SANE and FNE role, where you just kind of work on an on-call basis as you're needed.
Yeah, we some jurisdictions have full-time staff depending on their case volume in their counties. We are only an on-call system, except for our chief investigator. She works Monday through Friday and takes all day call during that time. So we primarily cover night and weekend call and occasional day call if she needs help.
Mm-hmm. So it's totally just like anything else, hit or miss. You could be really busy or really slow, I assume, just kind of.
Yeah, absolutely. I've gone 2 months I take about 8 call shifts a month typically. Wow. And I've gone almost 2.5 months without getting a call on any of my shifts. And I've had shifts where I've had 3 calls back to back. Sure. So it really, really depends. And the investigations really vary quite a bit. So sometimes when we're on scene, especially for our natural deaths, we may be there for an hour to an hour and a half. Typically what it looks like when we arrive on scene is we first touch base with the law enforcement in charge of the scene, just to make sure that the scene's safe. And then we get any information that they have on our decedent that we're working with. After we've talked with law enforcement, typically what my process is I like to walk through the scene, kind of get an idea of what I'm dealing with. And then from there, I'll interview anyone that was on the scene. So family, witnesses to an accident, just to get a better idea of their side of the story. And then once I do that, I go back to the decedent and I do my scene workup, where I'll walk through, I'll take my photographs of the scene and the body. I will assess for injury, fingerprints and DNA swabs if necessary, or if it's an autopsy case. After I've kind of conducted my interviews and my scene walkthrough, I call our medical examiner. I kind of give a narrative of the case over the phone, and we decide together whether we have questionable, if an autopsy is needed, and then our medical examiner, who we're speaking to, ultimately makes the decision if an autopsy is required. And then once that is determined, a lot of my job is a lot of phone calls to the donor network in the region, to the state office that will be performing the autopsy, I coordinate the funeral home's transport to our morgue. And then sometimes I have to call and speak to family as well, just to kind of get more of a history on the background.
Oh, interesting. So a lot of documentation.
It's a lot of documentation, and it's very different documentation from, like, I have to really draw a line in the sand when I'm in my sane role, because I'm very thorough and I measure all my wounds and I document what type of wound it is, an abrasion, a laceration. It's very different when you're a medical examiner investigator, because we on the scene can't make that determination. We can't decide what a wound is. That comes to the forensics pathologist that will be doing the autopsy. So a lot of our documentations, we're looking over the body, and I may look at something and with my experience know, oh, that looks like an abrasion or that looks like a ligature mark. But I just have to say there appears to be a defect located on the right wrist of the decedent, or there appears to be a defect to the chest of the decedent as well as to the posterior back of the decedent. And it's really more of a, this is what it looks like, but I'm going to let the forensics pathologist decide for sure.
Oh, interesting.
Because a lot of medical examiner investigators also are not nurses. So in my region, you don't have to be a nurse. You don't have to have any medical background at all. It's all completely on the job training in my region.
Oh, wow. Really?
Yeah, so it's very different. Like, you'll see some states that require nursing and you have some states who don't at all. And my state just happens not to be, but I will say my background in emergency and trauma nursing has helped me dramatically in my role.
Yeah. How did you did you say you took a training or a course to learn how to do that role?
Yeah, so there's a few different classes out there. I went through one through St. Louis that is put on. It's a week-long course down there, Monday through Friday, where you go through a lot of different lectures on death investigation. There's a lot of speakers from forensics anthropologists to pathologists to very experienced investigators and law enforcement. So I went through that 1 week class, and then really my training is on the job with the chief investigator, where you just kind of stay on orientation as long as you need to until you get a thorough understanding of the process and you get a good amount of different cases while in orientation. I was very fortunate on my orientation to get a lot of different experiences. I had a lot of naturals. I had multiple suicides. I had multiple accidents. I didn't have any homicides until I was off orientation, but then once you are off, we work very closely with the law enforcement in our region who have their own forensics crime scene investigators who respond, and we work very collaboratively on scene. So a lot of the time, for example, if a homicide does occur, crime scene and law enforcement will work the scene typically for hours prior to me even becoming aware of the situation, because they work like projectile assessments. They do their own scene photography and videos. And once they're done with everything, they call me in, because technically the medical examiner's office does have jurisdiction of the body. So they can't touch the body until we're on scene. And then we work the body together, taking photographs, looking for injury, and documenting anything that has to do with the decedent itself.
Oh, interesting. So you could see adults, elderly, anyone. Sorry, adults, children. That's what I meant. Children, or yeah.
Yeah, we respond to everything. We also do something called infant videos after a infant has passed away, where if it's like a questionable sudden infant death, or there's concerns that maybe something was in a crib that could have caused suffocation, we actually, after we do our initial investigation, which typically starts at the hospital, we work with law enforcement and crime scene, and then the patient's families to actually go to the home. And we do videos where the family kind of walks us through when they laid the infant down, when they checked on them, what position they were in, when they found them, what did they look like. And we're taking videos as well and taking photographs. And then all of that is also sent to our forensics pathologists, because then they can use the autopsy and the video to kind of piece together the puzzle onto what could have potentially happened to the infant. So yeah, we do absolutely the whole range of ages.
Wow. So that must be pretty challenging working with families and loved ones after, so immediately after someone has just been deceased.
It is. And that, honestly, that was one of my biggest concerns when I transitioned into this role. I will say my experience again in emergency and trauma, because I dealt with families in the acute stages immediately after the trauma, I kind of gained that ability to talk to them in that situation. But again, in that situation, it's not always dealing with the decedent. Usually they're not okay, but they're alive. So I really had to adjust my phrasing and also go in. You have to be very empathetic and very sympathetic in those situations. And you don't want to go in straight like, okay, tell me the circumstances. You don't want to seem like you're not being very personal about it because this is their loved one. So it just takes some practice in a variety of different cases to really learn how to speak to family in those situations.
Sure.
I will say it was a lot easier than I expected. I don't know if that comes from my nursing experience or just how the situations play out in real life. But typically, they're just very happy to have us on scene, helping answer questions as to what possibly happened to their loved one.
Yeah. 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 It must be nice to have somebody there who they feel like supports them, at that time.
Absolutely.
Yeah. That's extremely traumatic, I'm sure. Was there something that surprised you when you started doing that role?
I honestly, what probably surprised me the most is not realizing how often death is really around you in the world. Like, you don't realize, for example, like suicides. Like, suicide is really an epidemic. Like, it's happening everywhere. There's so many agencies working to help make sure mental health resources are out there. I never realized how much there was in the world until I got into this role. And that's where I really learned that self-care is extremely important, because in my sane role at the hospital, um, that alone can sometimes rub off on me, where I'm always around victims who have gone through such a horrible crime, and staying strong for them, and then just always thinking about them hours after the exam's done. Like, oh, I hope they're okay. I hope they do get the resources they need, or they utilize the resources we gave them. When it comes to outside the hospital as a medical examiner investigator, um, it really puts into perspective how much like first responders see in the world, and how that really does come home with you. Like, you really do see some really traumatic things. So I learned how important self-care is, and it really just gets you a better respect for when everything that those first responders see when they do have to respond on scene, and understanding that they like go home and they put that in the back of their mind and they're there for their family, but knowing that self-care is very, very important.
Yeah. Does your organization that you work for do anything to help support like vicarious trauma and to kind of support self-care for, the employees in general, or is that just kind of on your own?
We have an employee assistance program where on the hospital side, for my forensics role, we get 5 free visits with the therapist to talk about things per incident that we encounter. So that's really great. So that's great to talk to. And they have a lot of resources. They talk you through meditation, different community resources you can utilize. So there's a lot of support on the hospital side. And then also in my medical examiner role, our county has also an employee assistance program that we can use for vicarious trauma, talking about the incidents that we go through. And then we also just really support each other within our own group. Like, whenever there's a difficult call, my chief investigator always follows up within 12 hours of that call. So like my first infant death, I received a call that next morning, like, you had your first infant death. How did that go? Is there anything you want to talk about? How are you feeling about it? And just really supporting each other is extremely important.
Yeah, that's great. Yeah, that's really important. Yeah, I think now there's, of course, a lot more awareness. After COVID, people are starting to realize that, oh my gosh, this is really, really important.
Absolutely.
Yeah, so that's really good. So if nurses were interested in pursuing either type of work that you do, what would you recommend?
From the medical examiner side, I strongly recommend, if you can, reach out in your region. If there are investigators in your counties or in your region, see if you can shadow. Some places do have policies written where you can actually shadow for on the job to see if it's something that you could do, because it is not a job that's faint of heart. I honestly would say it takes a very special individual, and you have to have an interest in going to the scene and really being able to, in the moment, separate yourself from the situation to be able to objectively do your role. And then, like I said, work on that self-care afterwards. And I would say, if you're interested, try shadowing. Look into what options are in your area, because some have full-time positions, some have casual positions. Learn what that actual role commitment is. And then from a nursing standpoint, working in emergency, working in ICU, working in a trauma ER, I think those are very, very helpful in learning how to objectively identify injuries, being able to interact with people in the acute stages of trauma. So just really getting that experience, doing a lot of research. The International Association of Forensics Nurses has great resources for both death investigators as well as people interested in being a sexual assault nurse examiner. So I do encourage people to get a membership to that association to kind of learn more about it, talk to more people who are in the role, and make networking connections, because it's also not easy to get a death investigator role because it's really sought after by a lot of individuals. So network to kind of get to know people, get your foot in the door. And then as a sexual assault nurse examiner, again, do your research, see if it's something that you're interested in, join an association, read what the actual role entails, reach out to people who do it, see if you can do some shadow cases if possible, if some hospitals offer that. But really, yeah, just doing your research and seeing if it's something that you think you're interested in and you think you can handle.
Mm-hmm. Yeah, I think that's really good advice. And is there anything else that you'd like nurses out there to know about either of your roles in forensic nursing or forensic nursing in general?
I think forensics nursing, while it's been around for a long time, I think it is still a nursing specialty that's really trying to establish itself in the healthcare community. So if you're interested in it, get information, go after it. I know for a lot of people and a lot of programs, it's usually a role in addition to your primary role. So I think that's a deterrent for some people. Like, well, I have to work full time in my home position. Plus, I'd have to work casual as a death investigator or casual as a forensics nurse or sexual assault nurse examiner. So it seems like a lot. But if you're passionate about it and you want to help with that patient population, I will say when I'm on call, it doesn't feel so much like work as I'm filling a gap that a lot of areas can't fill. There's still a lot of regions that don't have access to the services we offer. So if you're interested in it, really look into it, join our specialty and help grow forensics nursing to as big as it can be. I really think we're getting closer to a time where forensics nursing is going to be expected in a lot of healthcare institutions as well as communities. So get in it early and help grow it and make it as good as it can be.
Mm-hmm. Yeah, I think that's great advice. All right. Well, thank you.